Hi, everyone. I'd like to introduce myself today. My name is Helena Mystery, and I'm the Director of Business Development for MICA and MIAC. So today, we're in a new year, 2021, and it marks our 10th year anniversary at MICA. So thank you, everyone, for attending today. Today's format of our webinar will be 30 minutes of a presentation by our speaker, Tim Sinnecker, followed by 20 minutes of Q&A. So that's a total of 50 minutes. After the webinar, after the presentation, if you would like to ask a question, you can do so by clicking the little hand raise icon, and I will unmute you and allow you to ask Tim a question. Alternatively, you can ask a question by typing it into the Q&A box, and I will read it out and ask Tim to answer the question for you. Today, we'll be recording the webinar, and we'll be following up with a short Q&A. With a short questionnaire. So if you could answer that, that would be great for us. It's very short and it will help us prepare for future webinars. The title of today's presentation is Quantitative MRI to Assess Tissue Damage in MS. A short description about today's webinar is that quantitative MRI aims to provide physical and chemical variables that can be compared between tissue regions and among subjects. It hence provides a way to access pathological changes of the central nervous system that may precede or accompany volumetric and/or focal alterations of the brain. Here in today's webinar, we describe and discuss recent developments in the field with focus on T1, T2, T2 star relaxometry, and quantitative susceptibility mapping, otherwise known as QSM, in MS. A short bio about our speaker today, Dr. Tim Sinnecker, is that he serves as a neurologist at the University Hospital of Basel in Switzerland and is a postdoctoral researcher at the Medical Image Analysis Center, MIAC, in Basel, Switzerland as well. His initial work at the NeuroCure Research Center, otherwise known as NCRC in Berlin, Germany, aimed to discover the potential of advanced neuroimaging techniques at 7 Tesla MRI in order to develop novel diagnostic and prognostic biomarkers in neuroimmunological disorders such as MS and neuromyelitis optica. After moving to Basel, he focuses on translation and integration of these methods to clinical and radiological cohort studies. So I will hand it over to you, Tim.
Unmute myself.
Okay, Tim. We can see your presentation, so that's great.
Okay, I hope this works technically, but it looks like. So welcome to this webinar on quantitative MRI to assess tissue damage in multiple sclerosis. Now I hope you can also see my screen and me in person. My name is Tim Sinnecker and I will first introduce myself. I'm working at the University Hospital of Basel as a neurologist, and I'm also working at the Medical Image Analysis Center in Basel. We have quite a long history. Since 1995, we are working in the field of international clinical trials when it comes to MR analysis. We spinned off from the University Hospital and are a non-profit entity. Together with IMECA, we are present on 2 continents and we can rely on a worldwide network. We offer a broad set of different MR analysis in setting of a certified system with 24/7 support. IMECA, on the other hand, is specialized on diffusion MRI and AI integration. Together, we can offer a broad set of advanced MR analysis tailored for a specific imaging study. And today's presentation focuses on advanced imaging techniques and how we can apply them to assess damage in multiple sclerosis in more detail. The first part of this presentation is about quantitative susceptibility mapping. The second part is about T1, T2, and T2 star relaxometry. So let's start with quantitative MRI in general. So quantitative MRI aims to provide physical or chemical variables that we then can use to compare tissue regions and, in a perfect scenario, subjects. Also, it provides a way to assess CNS pathological changes that are made preceding volumetric or focal changes. The ring sign is a prominent morphological feature of MS lesions on susceptibility weighted images, and this is also an interesting case to show the advantages of quantitative susceptibility mapping. It's quite interesting that if you look on SWI or T2 star weighted images and a high field strength in MS patients, then you will notice that some lesions will show a hypointense rim at the edge of the lesions. For example, here marked by the white arrows. These rims are not present at the edge of each lesion, and it's not visible in every MS patient. So what is special about these rims? Early studies have shown that these rims correspond to iron-rich activated microglia. And the question now arises, where does the iron come from? One hypothesis is that you have a high concentration of iron within oligodendrocytes. They need it because they need it as for the myelin-producing enzymes. And if you have an inflammation that leads to death of oligodendrocytes, then you have a release of the intracellular iron into the extracellular matrix. Another source for the iron maybe is that you have BBB breakdown with iron depositioning. Then iron is required for bacteria and other microbes for proliferation and growth. So the immune system is kind of trained to remove the iron from the site of the inflammation. And studies, for example, have shown that it promotes differentiation from macrophages into more pro-inflammatory M1 subtype macrophages. And these cells then take up the iron. During the process of inflammation, they move from the center of the lesion to the edge, taking the iron with them, and laterly form the iron-rich rim at the edge of the lesion. Then two scenarios can happen. So one scenario would be you have a continuation of a chronic active inflammatory process. Then the iron and the iron ring stays there together with the macrophages. And on the other hand, you can have a shift to an anti-inflammatory environment, and the iron and the macrophages will disappear. So that's the hypothesis we have so far. And indeed, a lot of studies, or there's increasing evidence that the iron-rich ring lesions represent smoldering lesions or chronic active, slowly enlarging lesions. They grow with a very low speed, so maybe much less than 1 millimeter per year. Here you can see one example from a case report. However, I think the evidence is not fully clear on this. So there's also conflicting reports that show that these ring lesions stayed stable over time. But I think the biggest issue is that the follow-up interval and the studies that are available so far is limited to 1 or 2 years, and then it's really hard to mention whether the lesion is growing or stable because they grow with a very low speed. So this is one example how the magnetic properties of the tissue allows us to define a lesion type in MS. And there are other lesion patterns in multiple sclerosis that were observed. And it's not always easy to differentiate them with conventional MRI techniques. For example, there's one lesion where we believe that it's characterized by loss of diamagnetism, so extensive degree of demyelination, and the other lesion that's characterized by iron depositioning. Those features will lead to signal loss on SWI, so to a dark signal on the SWI sequence, and you won't be really able to differentiate them with this technique. That's where quantitative susceptibility mapping comes in. With this technique, you can measure the magnetic susceptibility within a lesion quantitatively, and therefore better differentiate between demyelination, where you have not so high increase in magnetic susceptibility, versus iron depositioning, where you have a strong signal. Here you can see that these different lesion types or patterns are likely to represent different stages of MS lesions. It's not fully clear yet, but here's one example where you can see that a lesion at baseline that has a high potence core on the SWI sequence changes its morphology during a follow-up period of roughly about 4 years in this case. You can see that the iron is redistributed from the center to the edge and now forms the high potence ring. On the other hand, you here see another development or evolution of the lesion. At baseline, again, you can see that the lesion has a high potence core, and in the follow-up image, the lesion has shrunk a little bit, and a high potence center or rim is not visible anymore. New lesions often show specific features on QSM maps. Here you can see 2 new lesions that were not visible at the baseline scan on the top, but are clearly present on the follow-up image on the bottom. And these lesions exhibit high magnetic susceptibility, as shown by a hyperintense QSM signal here. And that's quite characteristic for new lesions. So in the very acute phase, it's often the case that you don't have iron deposits in lesions, but quite early in the disease process, the magnetic susceptibility rapidly increases within the lesions and remains there in a quite high level in the next time, and then over the next couple of years, the magnetic susceptibility within the lesion seems to decrease substantially. When you look in the long term, so maybe after 10 years or so, the data we have now looks like that there's very low magnetic susceptibility within lesions if they are inactive, and that may help to differentiate them from the acute lesions. The quantitative susceptibility mapping is not only an interesting method when it comes to focal lesions and lesion morphology, but also it helps to describe iron depositioning in different brain compartments in MS patients in comparison to others. Here's an interesting study that has investigated iron depositioning in the basal ganglia and the thalamus in MS versus healthy controls. On the left side, you can see that there's increased iron depositioning in the basal ganglia, for example, in MS, and that this pattern is even more pronounced in progressive MS patients, as you can see on the right. Also, changes in iron content in the basal ganglia were related to clinical disability as measured by the EDSS score. Now let's focus on T1 relaxometry. T1 relaxation time is sensitive to the CNS tissue structural organization and free water protons, and the T1 relaxation time increase in case of loss of structural organization of the tissue and density. Early studies 10-20 years ago have found that T1 is prolonged in MS in different brain compartments. It's prolonged in the normal appearing white matter, in the thalamus, and also in the cortex. Furthermore, it was shown quite early that it is associated with clinical features such as fatigue, for example, and it is able to predict the current and future clinical disability. Here, for example, shown with the EDSS score, or here in another study also for the MSFC score and the TBT. More recent studies have investigated whether T1 relaxation time is a marker for remyelination. And there's a clinical study on 17 patients with immature fumarate, and they have assessed the T1 relaxation time quantitatively at baseline and after 12 months of treatment, and they found a change in the T1 during the treatment period, and they suggested that this was associated with remyelination taking place during treatment with dimethyl fumarate. I think there's another very interesting concept when it comes to T1 and quantitative T1 changes in focal areas of the brain. And I will now show you a new concept that is highly interesting, I think, for the future and also for the clinical routine. So the idea is that you can create atlases, MRI atlases, of normative values of T1 by using a database of healthy controls that also comprises scans from different scanners with different protocols. And when you have such an atlas, and here's one example of normative T1 values, then in the next step, you can use your individual MRI data of a specific patient and scan to compare T1 values within this patient to the atlas. And this was done here by using z-scores. Of course, what's kind of obvious, you will see the MS lesions. So the MS lesions will pop out in red here, for example, but that's not the interesting part. The interesting part is that you will see much more abnormalities around the lesions. So you can see that the lesion next, the white matter next to the lesions is not normal at all. And you will also see that you can identify much more areas in the brain that are abnormal in your individual patient. We also had a look into quantitative T1 mapping in patients with NMO, and we tried to identify abnormal tissue in aquaporin 4 rich areas in NMO patients. However, we did not found them in the absence of lesions. In contrast, we used the same techniques in MS patients where we observed a lot of changes, and that also lead to conclude that the NMO is indeed a more focal disease, and MS also is characterized on diffuse tissue damage on top of the focal lesions. So now I want to switch to T2 relaxometry. The T2 relaxation time increases in the normal appearing white matter in MS, and T2 and T2 star relaxation times were found to correlate with motor and cognitive deficits, quite the same as T1. But there is a new application of this technique in the recent years, especially when it comes to high field and ultra high field MRI. And that's T2 star relaxometry of the MS cortex. So you may know that cortical lesions are, on the one hand, a hallmark of MS and very important for some clinical features. But on the other hand, we have kind of trouble to display them in the MRI scan. Even when you look at 7 Tesla MRI with a very high resolution and the strong magnetic susceptibility effects, the very brilliant contrast, you will only find a few of them, and you will miss the majority. And at 3 Tesla, for example, it's you see even less, and at 1.5 Tesla, it's kind of a chance to see any of them. T2 star mapping can help to identify areas in the cortex that are abnormal from the signal. And here's a study that has investigated early MS, relapsing remitting MS, and also progressive MS patients. And as you can see here, it was observed that large areas of the cortex are indeed not normal. And this is not just an imaging finding, it really translates to clinical features. For example, here you can see a correlation of abnormal T2 star values in the cortex with disability as measured by the EDSS score or the MSSS score. And it also correlates with cognitive function. This study here, for example, has assessed processing speed, executive functions, and verbal learning and memory. And all these features are associated with T2 star increases in the cortex. Also, other studies have observed that more global cognitive measures quite closely correlate with increased T2 star values in the cortex. For example, as measured by the TMT test here in the bottom of this slide. So this was a short overview on quantitative MRI. In conclusion, I think quantitative MRI provides us new opportunities to assess not only the diffuse pathological changes within the CNS, but also the focal ones. Novel imaging markers such as intralesional iron content and individual Z-scores may help us also to pave the way towards a more patient-tailored treatment and personalized medicine. We have for sure overcome some challenges, but I think the results we have so far are quite promising for the future. So thank you very much for your attention so far, and let's hope for a good discussion.
Okay, thank you, Tim. So if anyone has any questions, please raise your hand or type it in the Q&A box. So Tim, I have a question from Maxime Decoteau. His question to you is, what is the minimum spatial resolution in QSM to detect the RIM effect you showed in the first part of the talk?
Yeah, so it depends on the field strength a little bit, because if you have a very high field strength like 7 Tesla, the susceptibility effects are so strong that you don't need such a high resolution to detect them. Usually 1 by 1 by 1 will be okay. If you go, or if you scan on 3 Tesla, for example, or even 1.5 Tesla, you will need a higher resolution to detect them. Good, for example, would be 0.5 by 0.5. Yes.
Okay, great. His next question is, do you have 3T QSM protocols available to show the RIM effect?
Yeah, this is achievable. At 3T, I don't have them here yet on this PC, unfortunately, but this is possible. It's even with a lot of caveats, achievable maybe at 1.5T, but not at so good quality. But at 3T, I think this is feasible. You will not reach the same sensitivity as at 7T for sure, but you won't miss a lot of rims at large lesions, at least either. Small lesions may be a problem.
Okay, Great. So how about T1, T2 relaxometry? Is it possible on 3T scanners?
Yes, I think 3T is perfectly suitable to create T1, T2 maps, especially the MP2 range sequence is great at 3 Tesla and produces really nice images. And for example, the z-scores and the normative values and atlases I showed you previously are based on 3T scans.
Okay, great. So I have another question from JC Hood. About acquisition protocols, are the sequences needed for these modalities available on most clinical scanners? From what I have seen, some of these sequences need fine tuning, so I'm wondering if this is easily deployable in a clinical trial.
Yeah, that's true. I think for QSM, it's the hardest to get this into a clinical trial. But for example, T1 mapping, it should be not a big issue anymore because MP2 range sequences are standardized nowadays and available for a broad set of Siemens scanners.
Okay, great. So Tim, my next question comes from Marco, who says, are the analysis mostly based on visual rating, or is there a potential for automated analysis also in the clinical routine?
Yeah, there are, I think, two scenarios. So the first scenario is you want to know about the tissue properties within a lesion. And in that case, I think it's quite easy to automate because you only need the lesion maps. You can get them maybe fully automatically from a 3D FLAIR scan and apply AI-based algorithms on that to extract in the end these lesion masks, so T2 weighted lesion masks from the FLAIR images. And then you can register or co-register your quantitative sequences to this to the FLAIR image, use the lesion masks, and then you can make statistics on the quantitative measures within a specific lesion. You can also track then these lesions over time and see how the quantitative measure develops over time in an individual lesion. That's feasible. And there's another scenario where you want to use quantitative imaging to see occult damage. And then of course you can use atlas-based segmentation approaches to define and automatically segment compartments of interest, and then you can also compare the T1, T2 or magnetic susceptibility within this compartment over time and between subjects. So the short answer is yes, there are a lot of solutions, I think, to calculate it automatically.
Okay, great, thank you. I have another question from Marco Canzetti. What is the difference or added value of T2 cortical maps instead of T1 weighted / T2 weighted cortical maps?
Yeah, that's an important question. So I think just by looking on the cortex on when you having T1 weighted or T2 weighted scans or MRIs, you will only see the tip of the iceberg of cortical lesions, and you will miss for sure the majority, even at 7 Tesla. Especially the subpile lesions are very hard to detect. And even if you have a very high resolution 7T scan, you will not see the base of the subpile lesions in many cases. And the quantitative approach helps you to see these subtile and diffuse changes, especially if you compare it to normative values or a group of Percy controls.
Okay, great. I have another question from Maxime de Coteau. I believe you already answered it, but if you could comment on it, it'd be great. Do you have an idea of how these quantitative measures are reliable across MR vendors? And can you comment on measurement error?
So that's a very important question, which is not fully solved yet. In theory, and that's the promise developers make, there should be comparable, because you measure, in theory, you measure a true physical variable unit. But I'm not really convinced on that. There are for sure variabilities depending on the protocol and scanner, and I think we don't understand so good at the moment, and so you need a database in the background that has different scanners and different protocols for comparison.
Okay, great. My next question comes from Laura Gaetano. Is the direction of the rim lesion reader dependent? How clear are those rims?
Yeah, these rims are quite impressive if you see them. So it's not just so there are 2 different kind of rims, and now I'm talking about the iron rim, the iron ring at the edge of the lesions. These are very impressive if you see them, and I think it's a very specific finding. And then there are these very tight, small rims at the edge of acute lesions, described by the NIH group, and they have another correlate. I didn't talk about this today, and they probably their histopathological correlate are proteins, cytokines, and a lot of immune cells packed at the edge of an acute inflammatory lesion, and these rims are much harder to detect, but the iron rims it's a very specific finding, I think. Yeah.
Okay, great. Does anyone else have any other questions? Please raise your hand or type it in the question box. I'll leave it for a minute, and if not, we'll wrap this up. Okay, I don't think there are any more questions. Thank you everyone for attending today. We greatly appreciate your presence. And as I said earlier, after the webinar, we'll send out a questionnaire, and it's very short, and I promise it's not boring. You filling out the questionnaire really helps us plan future webinars, so I appreciate any feedback that you send us. Thank you very much, Tim, for your presentation today. This was a great talk, and I would like to thank everybody once again and hope to see you at future webinars. Have a great day, everyone.
Thanks, and have a nice day.